Awareness. Julian Barker, you are called to see a patient on the surgical ward by the sister because a patient describes being aware during surgery. You did not anesthetize the patient. How do you deal with the situation? Inform the anesthetist involved and the head of the department. There may be a departmental policy or someone with a special interest in awareness. Interview the patient with a senior colleague. Ideally, the anesthetist involved should do this. Always have a witness present. Establish the events surrounding the time of alleged awareness by reviewing the anesthetic charts, discussing with the anesthetist involved and the patient. Establish whether it is true recall or dreaming. Recall may be further divided into explicit, patient can recall conversations which took place in theater, or implicit, behavioral changes postoperatively due to intraoperative subconscious learning. Establish whether the patient was in pain. This has implications for long-term psychological sequelae such as nightmares and flashbacks. If there was a clear lapse in the standard of anesthetic care, then honesty with an admission of fault and an apology is appropriate. Document all conversations and assessments in the case notes. Hospital management, including the legal department, may need to be informed in order that the events can be documented for future reference in case of legal action. Offer counseling for the patient. What do you tell the patient? It is important to acknowledge the patient's feelings and let them know you believe what they are saying. This helps with the well-recognized psychological sequelae following an episode of awareness. These include anxiety, insomnia, nightmares, depression, a morbid fear of hospitals, and doctors, and a preoccupation with death. It is helpful to explain why awareness might have occurred through no particular fault but instead because of the need to minimize the doses of anesthetic agents given. If there is clear fault on the part of the anesthetist, then it may still be wise to admit it. Although this is an admission of negligence, some say it may help to reduce anxiety for future anesthetics if there was a definite reason for the awareness. In summary, a full explanation of the events and an apology are recommended. What is the legal situation regarding awareness? An anesthetist has a duty of care towards a patient. A patient who is going to have a general anesthetic expects to be asleep and unaware. To decide whether there is a breach in the duty of care, the Bolam test is applied. In the 1950s, Bolam's leg was broken during a course of ECT. Bolam's expert witnesses claimed that the omission of a muscle relaxant was negligent. The experts called by the hospital were of the opinion that muscle relaxants were not essential. The judge ruled that a doctor is not guilty of negligence if acting in accordance with a practice accepted as proper by a responsible body of medical opinion, even though a body of adverse opinion also exists amongst medical men. An anesthetist must therefore prove that the technique he used is one that is considered to be reasonable by his peers. This is done through review of the anesthetic records by expert witnesses. If there is evidence of a shortfall in the standard of anesthetic care, then the anesthetist is guilty of negligence. If the awareness can be clearly linked to the page 0 or anesthetic technique, causation, then compensation is payable. When is awareness most likely? At induction and intubation, on transfer from the anesthetic room to theater, during procedures involving the use of muscle relaxants, TIVA. During procedures where low concentrations of volatile are used deliberately, e.g., LSCS or hypotensive patient, at emergence. Awareness with explicit recall has a reported incidence of approximately 1/500 and is most common during obstetric GA, especially at intubation. Awareness with pain is far less common. What are the causes of awareness? Induction, low doses of drugs as above. Intubation, too early or delayed due to difficulty or waiting for relaxant to work. Transfer. Induction agent levels fall, adequate partial pressure of volatile builds up. During surgery, equipment failure, e.g., breathing system leak, disconnection, vaporizer, malfunction or exhaustion, TIVA line tissued. How do you monitor depth of anesthesia? Simple clinical signs: MAC, isolated forearm technique, spondyloskeletal muscle activity, esophageal contractility, evoked potentials, amplitude, e.g., spectral edge frequency, cerebral function monitor. Bispectral index, heart rate variability, BP, HR, sweating, lacrimation, pupils, based on population studies, frontalis, lost with relaxants, depth of anesthesia related to frequency of contractions, visual, auditory, somatosensory. Changes in latency and frequency. When significant EEG activity is seen, processed EEG makes interpretation easier. Fathom monitor, loss of respiratory sinus arrhythmia, clinical assessment of the stages of anesthesia. 1.2, respirations, regular, irregular, pupils, normal, dilated, disconjugate, constricted, muscle, tone, normal, increased, tense, eye reflexes, loss of eyelash, loss of eyelid, loss of, corneal, loss of, pupillary light, stage 1. 2. Plain, laryngeal reflexes, swallowing, highest risk of laryngospasm. 3. Regular. 3. Plain eye, plain, IV. 4. Regular, hypoventilation, irregular, hyponia, apnea. 3. Progressive dilation with increasing depth. Dilated, fixed, increasingly, relaxed. Aspiration under general anesthesia. Cyprian Mendonca, a 20-year-old patient undergoing a hemorrhoidectomy, has been anesthetized and has an LMA in place. He is positioned on the left lateral side for a caudal epidural. As you are about to perform the caudal epidural on the patient, you notice a copious volume of fluid in the LMA tube. What is the immediate management? Stop the procedure and keep the patient in the left lateral position. If possible, apply a head down tilt. Administer 100% oxygen. Suction all the fluid through the LMA tube. If the laryngeal mask does not maintain the airway adequately, remove it and administer oxygen via tight-fitting face mask. Further management depends on the degree of aspiration and whether or not the patient breathing spontaneously. If the patient is breathing spontaneously, apply cricoid pressure. Apply mask CPAP and consider deepening anesthesia. Avoid cricoid pressure if the patient actively vomiting, risk of esophageal rupture. Intubate the trachea with the aid of a muscle relaxant, and apply suction to the trachea. A bronchoscopy can be performed to visualize any signs of aspiration. If the regurgitation is minimal, the LMA is correctly placed, and the patient remains stable without desaturation. The tracheobronchial tree can be suctioned through the LMA using a fiber optic scope, provided that the airway reflexes are adequately obtunded. If the patient is apnoic, intubate immediately and commence ventilation. Treat as an inhaled foreign body by minimizing excessive positive pressure ventilation until the endotracheal tube and the airway have been suctioned and all aspirates are clear. A bronchoscopy could be performed to look for signs of aspiration. How would you diagnose aspiration? Diagnosis by clinical examination, which may reveal any of the following. 100% is laryngospasm, airway obstruction, bronchospasm, wheeze, crackles, hypoventilation, dyspnea, apnea, desaturation, bradycardia, cardiac arrest. Monitoring: decreased oxygen saturation, decreased lung compliance, increased airway pressure, increased slope of the capnograph trace. Investigations: tracheal aspirate may be acidic. Negative finding does not exclude aspiration. Chest radiograph: diffuse infiltration, arterial blood gases, hypoxia, hypercarbia and acidosis. Bronchoscopy: visualization of aspiration fluid. What would be your subsequent management of this patient? Sedation, analgesia and intermittent positive pressure ventilation, PPV via net. Suction of the airway, optimization of FiO2 possibly with positive end expiratory pressure, PEEP. Bronchoscopy and bronchial lavage if necessary, emptying of the stomach with a large bore nasogastric tube before extubation. Monitoring respiratory function, chest X-ray looking for evidence of pulmonary edema, collapse or consolidation. Further management depends on the clinical picture and results from the investigations. If the SP02 is more than 95% on minimal oxygen and the chest X-ray is normal, the patient can be extubated and monitored for signs of respiratory complications. If the SpO2 remains at 95% and FiO2 is less than 0.5, heart rate 100/min, respiratory rate 20/min and the patient remains apyrexal, the patient can be extubated and the oxygenation and atelectasis can be improved with CPAP and chest physiotherapy. If SpO2 remains 95% despite Phy02 being 0.5, there may be solid food material obstructing part of the bronchial tree. The patient should be transferred to the ICU postoperatively for ventilatory support. Extubation should take place in the left lateral position with the head down tilt. Further management: repeat the chest X-ray and blood gases, sputum culture. Antibiotics are not routinely used. Explanation to patient and relatives: what is the role of steroids and antibiotics? Steroids may modify the inflammatory response early after aspiration but do not alter the outcome. They may potentially interfere with the normal immune response. Prophylactic antibiotics are not routinely indicated but they may be required to treat subsequent secondary infections. What are the risk factors for aspiration? Patient factors: full stomach, fasting from food for less than 6 hours, intra-abdominal pathology, intestinal obstruction, inflammation, gastric paresis, drugs such as opiate analgesics, diabetes, uremia. Infection and trauma, esophageal disease, symptomatic reflux and motility disorders, pregnancy, obesity, uncertainty about time of intake of food or drink. Anesthetic factors: insufficient depth of anesthesia with airway reflexes, such as coughing, hiccups, or laryngospasm, or gastrointestinal motor responses, such as gagging or recurrent swallowing. Being evoked and causing regurgitation. Aspiration during IPPV with a mask. Anesthetic gases may pass into the stomach and may increase the risk of regurgitation. Surgical factors: upper gastrointestinal surgery. Increased intra-abdominal pressure, e.g., laparoscopic surgery. Aspiration during anesthesia. The LMA does not reliably protect the lungs from regurgitated stomach contents, although it may act as a barrier at the level of the upper esophageal sphincter if it is correctly positioned. The incidence of clinically detectable regurgitation with the LMA is approximately 0.1%. The incidence of aspiration is low, approximately 0.02%, which is similar to the incidence of aspiration with tracheal intubation in elective patients. The following are practical guidelines to minimize the risk of aspiration while using an LMA. Avoid use of an LMA in patients with an increased risk of aspiration. Ensure adequate anesthesia during insertion of the LMA and during surgery. Avoid lubrication of the anterior surface, excessive lubrication, or use of lubricants containing non-aqueous solvents. Avoid gastric distension during positive pressure ventilation. Minimize peak airway pressures. Avoid inadequate paralysis. Therapeutic strategies to prevent aspiration in patients with risk of aspiration. Ensure that the patient is adequately fasted. Measures to increase gastric pH. Measures to reduce the volume of gastric secretion. Application of cricoid pressure. Protection of the airway by a cufflet. Extubation in the lateral head-down position after suctioning the oropharynx. The respiratory damage following aspiration depends on the acidity and volume of gastric content. 30 ml 0.3 m sodium citrate given 15 to 20 minutes prior to induction of general anesthesia and H2 receptor antagonists, such as ranitidine 150 mg orally or 50 nmg intravenously, increase the pH of the gastric juice. Metoclopramide increases gastric motility and reduces the volume of gastric fluid. Key points: as soon as regurgitation is recognized, the airway should be thoroughly suctioned and 100% oxygen administered. Further management depends on the clinical condition of the patient as indicated by oxygen saturation and respiratory signs. Regurgitation and aspiration can be minimized by avoiding the use of an LMA. Regurgitation and